Okay, we're going to go ahead and get started. My name is Katie Liveoak. I'm one of the clinical pharmacists here at Aegis, and this morning we're going to be talking about bariatric surgery and the impacts that it can have on specific medications. First off, thank you all so much for joining us and spending your morning with us, and I'm hoping that you all can take away a couple of clinical pearls related to bariatric surgery and the impacts it can have on medication. First, just on my objectives, we're going to list the different types of bariatric surgery procedures, determine the implications that those surgeries can have on medication pharmacokinetics, and provide an overview of selected literature to help you enhance safe use of these medications following bariatric surgery. And I also just wanted to kind of connect the dots on why this topic is important. First, we do know that obesity has doubled, if not more than that, over the past 40 years, with on average greater than 250,000 surgeries per year in the United States, with over 580,000 surgeries worldwide. These surgeries can lead to anywhere from 40 to 70% weight loss for the individual. And to put that in comparison, weight loss medications paired with the lifestyle changes only leads to about 7 to 12% of weight loss. For completeness sake, I have included the abbreviations that I'll be using during the presentation or that are listed within charts. The three that I did want to point out because I will be using them frequently is AUC, which is area under the curve, Cmax, which is a maximum concentration of the medication, and then Tmax, which is the time to peak concentration of a medication. On this slide, I've listed all of the bariatric surgeries that are available within the United States, and I have highlighted and bolded here the two that we're going to review today. These are the two most common procedures that are performed in the United States. So you have a restrictive procedures and malabsorptive procedures. The most common restrictive procedure by far is a sleeve gastrectomy. If you look to the right, I've included a diagram so you can see a little bit of what happens when they complete this surgery. So they remove about 80% of the stomach, creating a tubular path, and that is going to reduce about, like I said, 80% of the stomach. So now the stomach is going to hold a considerably smaller amount of volume. This is going to reduce the amount of food the individual can take in, so therefore reducing caloric intake. And then it's going to affect gut hormones. That's going to reduce hunger, make the patient feel more full, and help with blood sugar control. When you go down to the malabsorptive procedures, the most common is the Roux-en-Y gastric bypass, also known as gastric bypass surgery. It's a bit more invasive and complicated, but essentially, if you look at this diagram, bottom right-hand corner, you'll see that you are removing a portion of the stomach. This portion of the stomach, just so that you're aware, remains in the patient's body. They create a very small stomach pouch that is 30 milliliters, so about the size of a walnut. It will only hold about 2 tablespoons of volume or about 1 ounce. Then they take a small portion of the small intestine and divide it. They connect one portion of the small intestine to this small pouch, and then they create, as a final step, the other portion of the intestine farther down into the larger intestine. So, again, a bit more invasive. Both of these surgeries, on average, lead to anywhere from 50 to 80% weight loss for patients. And kind of just keeping in mind what is occurring here so that you have an idea of how this is going to impact medications in the upcoming slides. The pharmacokinetic considerations I have listed here, these are specific for the gastric bypass, so the Roux-en-Y surgery. You have anatomical changes, which I covered in that previous slide, and I've paired that here with the physiological changes that occur once those things occur during surgery, and then the expected impact that these could have on drug kinetics. The main thing that I would like to point out is that it can affect all of the pharmacokinetics, but specifically you have changes to absorption, changes that can affect the rate and or extent, and then you get into issues with drug metabolism, how the medication can be distributed, and not listed here, but also equally important is just the solubility of a drug. And so, how when a patient takes a medication, it is dissolved and then able to be distributed throughout the body. Post operative recommendations, I will give a disclaimer. There is some variability depending on the surgeon, the institution, and the specific procedure. So, if you have a person who has had this surgery, I would encourage you all to ask about their post operative recommendations. But I did want to include some of the most common ones so that you kind of have an idea of what most patients are given as instructions after surgery. So, immediately post op, we're going to restart most all medications the same day of surgery. We have to restrict medication size for the first 2 to 6 weeks. I will let you know that there are some surgeons that want the medication size restricted for the entire lifelong trajectory following surgery. The majority of this is accomplished by tablets being crushed or converted to liquid formulations. So, if we're crushing tablets, knowing that you can't use extended release, sustained release, things like that, you would have to switch to an immediate release to safely crush. We also employ things like sublingual, oral disintegrating tablets, and transdermal formulations to help get around the medication size as well. Patients are encouraged to increase fluid intake as they progress through the first couple of weeks. They do increase their caloric intake. I've listed out some general recommendations. So, looking at week one, 400 calories per day, progressing up to 6 months when they get more to what would be considered a regular diet. A couple of other things to consider are patients are no longer allowed to take anti inflammatory drugs. So, all of your NSAIDs, things like Motrin, Aleve, products like that. The reason why is the stomach pouch that has been removed is still sitting in the patient and has blood supply. So, if a patient's to get a GI bleed from an NSAID, you no longer have the ability to access it like through endoscopy. You would actually have to open a patient up to access that pouch in the event that there was a bleed. So, we just avoid NSAIDs. And then patients do have vitamin supplement recommendations that are taken lifelong. Now I'm going to switch to some substances that we found in literature that seem to be most impacted by these surgeries. The first I wanted to go through is alcohol. One thing that we do know is that oftentimes with obesity, there is sometimes a component of, for lack of a better word, addiction to food. And so when you take away that, then there's an increased risk for addiction to other substances. And there is a decent amount of literature that these patients following surgery are at increased risk for alcohol use disorder. And when you see this slide, you may understand more of why that is. So, with alcohol, you get a more rapid and extensive absorption, and this is specifically following the Roux-en-Y gastric bypass. And subjects within this specific study had blood alcohol levels that far reached above legal driving limits within 2 minutes. And so looking at the y-axis here, we have the blood alcohol concentrations and the x-axis represented in minutes, and you see how quickly that blood alcohol concentration jumped up. For reference, these subjects were given 0.3 grams per kilogram of alcohol per their actual body weight. We believe that this happens because of accelerated gastric emptying as well as the reduction in alcohol or gastric alcohol dehydrogenase. Lithium, this is a frequently used mood stabilizer for the treatment of bipolar disorder, is a very narrow therapeutic window, meaning that a very small window of where it can be safe. So zero point 0.8 to 1.2 milliequivalents per liter is the plasma level, and anything above that, specifically lithium levels that reach 1.5, you're starting to risk toxicity, and lithium can be very dangerous at levels outside of this therapeutic window. Clearance of lithium is thought to be greater in obesity. So when you think about significant weight loss that I mentioned earlier, we're reducing the clearance of lithium. So patients are going to hang on to it longer, putting them at risk for increased toxicity. When we review the literature, the monitoring for lithium levels following a bariatric surgery is to get a level at baseline weekly for the first 6 weeks, every 2 weeks until 6 months post op, monthly until they're 1 year, and of course, immediately if symptoms of toxicity are present. The other thing to keep in mind is that patients are often held NPO and are not allowed any water 12 hours prior to surgery, so this increases the risk of an early toxicity as well, as dehydration can lead to toxicity. This is a review of literature for lithium toxicity after bariatric surgeries. You can see you have the Roux-en-Y and the sleeve here. They provided the gender and the age of the patient, the time following the surgery. Some of them did give the amount of weight loss, and what I want to point out here is how high some of these lithium levels got in such a very short amount of time. Truly, anything over 1.5 is actionable, and of course, a patient would need to have lithium held, increased fluids, and things of that nature to help reduce the toxicity. I've included also how that toxicity manifested. The recommendations essentially from this literature was to, of course, increase monitoring and to monitor and educate patients on symptoms of toxicity and reduce the dose if needed to prevent or eliminate toxicity. There was a decent amount of literature related to antidepressants. The first being duloxetine. The first study I have listed here was 10 patients. This was 1 year post gastric bypass, and then they matched these 10 patients to non surgical controls. And what they concluded was that there was a reduction in area under the curve. So we have less exposure of the medication to the patient's body, but in a decrease in Tmax as well. So you have a faster onset. That Tmax was 6 hours versus 2 hours, respectively. The second, looking at sertraline, brand name Zoloft, there was a reduction in an area under the curve and Cmax. The Cmax went from 50 to 19. That was pretty substantial, and that was in nanograms per milliliter. So kind of keeping in mind, thinking about, those of you that maybe use our Accurise ID, and you are trying to detect levels of some of these medications, and you get an unexpected negative and aren't realizing the patient has had a gastric bypass surgery, that this could be one of the reasons why. It's just the patient is having less exposure to the drug. The third, escitalopram, brand name Lexapro. They did not specify the dose here. There were only 4 patients, and they looked at a 2-week mark versus a 6-week mark. At the 2-week mark, there was a 33% plasma concentration reduction, and then up to a 19% reduction at 6 weeks post-op. Ziprasidone, brand name Geodon, it's an atypical antipsychotic commonly used in a variety of different behavioral health diagnoses, including schizophrenia, bipolar, and some treatment resistant states. This one I included for a couple of reasons. One, this is the first reported case of primary mania that occurred following bariatric surgery. So, understanding just outside of the things that can happen to a patient when they have these procedures, that there are scenarios where you may have an individual who has a decompensated state. This also is important because ziprasidone, as well as lorazepam, which is Latuda, requires specific caloric intake to be absorbed. And when you think of the restrictions post-op and the size of the stomach, you can see why some of these medications either have to be avoided or doses increased to overcome. So, patient underwent a Roux-en-Y gastric bypass 2 months post-op, presented to the emergency department, decompensated. They did a full workup and started ziprasidone, and then eventually stabilized the patient on 80 milligrams orally BID, so twice daily. With the Latuda, the impacts were dramatically different. We saw kind of 60 nanogram per milliliter reductions in the urine levels, and all of the patients that were maintained on lorazepam and ziprasidone had to be changed to overcome the effects of the surgeries. There was one case report on buprenorphine in a 45-year-old who had received a sleeve gastrectomy. There was a drop in a BMI from 42 to 24 post-op, so almost a 50% reduction of the BMI here. And they looked at the area under the curve at 1 month and at 12 month. There was a 1-point drop from 43 to 42. This change in concentration was deemed to be due to a decrease in oral pH, which is common following a gastric bypass surgery and impacts the oral absorption. There were no recommendations for change, but just to be mindful, you may want to increase the monitoring of buprenorphine in patients who have undergone these procedures, just to ensure that they're getting adequate absorption sublingually. Morphine IR was studied in 25 patients following a gastric bypass surgery, and they actually served as their own controls. So, 30 milligrams of morphine solution was given at every visit, pre op, 2 weeks post op, and 6 months post op. These results were statistically significant, and Tmax, Cmax, and area under the curve all increased as the BMI continued to reduce. And the patients were reporting sleepiness and drowsiness, so increase in adverse drug reactions. The authors did conclude and encourage that if you have a patient on a morphine immediate release product, that dose reduction may be warranted before a surgery to prevent any type of adverse effect. If you don't want to change the drug, increase monitoring and education on the ADRs, and reducing post-op if indicated. Looking at morphine sustained release, there were 12 patients that were greater than 2 years post-op, so kind of out of the window of your most impactful pharmacokinetic issues, but this was gastric bypass surgery, and then they paired them with non surgical controls. They just gave them a one time dose of morphine, sustained release, 30 milligrams, and then they measured Cmax, Tmax, and area under the curve. And you can see here that there weren't significantly different changes. These were all blood level monitoring and not statistically significant, and no dose adjustments were required. Now, in this scenario, had you changed it to immediate release, what I said in the previous slide would be more applicable. Oxycodone, we do know, can have impacts or be impacted by these procedures. They looked at, in this one study, controlled release, so sustained release. These would be your Oxycontin type products, and then liquid formulations. And there was a 14 or a little greater than 14 higher bioavailability for patients who were post gastric bypass compared to their healthy volunteers. The post gastric bypass patients experienced shorter absorption lag time, so a quicker onset of the medications, 11 and a half minutes versus 14 minutes, respectively. Methadone was evaluated, and they looked at the kinetics following the sleeve gastrectomy. And there are notes of decrease in Tmax, increase in patients' exposure to methadone. Serum concentrations for these patients were followed for 7 months post op, and they noted a threefold increase in area under the curve from baseline to 7 months in that observation period. The increase in that area under the curve was likely due in part to an increase in the bioavailability of the methadone. A couple of key takeaways just from a brief overview of the literature and what we know about these surgeries is that bariatric surgery can impact medication pharmacokinetics. This may impact period of detection in our definitive testing, which can lead to unexpected results. This impact we know is going to be highest within the first 6 months. Clinicians are encouraged to be cautious of changes and medication effects post bariatric surgery and to monitor closely. Therapeutic drug monitoring is highly recommended for narrow therapeutic drugs such as lithium, and then watching for malabsorption of drugs that require administration with a specific caloric intake, namely ziprasidone and lurasidone, and then just educating patients about the potentially dangerous increases in Tmax and Cmax of substances such as immediate release morphine and alcohol. Here is our complete clinical team at Aegis. I've included our telephone number as well as our email. If you guys have questions related to any of your patients who have undergone bariatric surgery and you would like to understand the metabolic processes more and how to more safely manage these medications, or have any assistance in interpreting unexpected results, we would be more than happy to help you guys. And with that, I would just like to say thank you all for attending today, and feel free to reach out again if you have questions.